Welcome back. So now that we've started talking a little bit about the history, let's go ahead and jump into the actual terminology we're going to use throughout the semester. And I don't want you to get overwhelmed with the terminology. I put most of the main words in bold, and a lot of these you've already seen before. So I just want to make sure that you've seen them, and when you see them again, you know what it is, and you always have a reference to go back to. So let's go ahead and start with one of the tougher definitions, and this first one's going to be health. And health, I say, is a tougher definition because health depends on a lot of factors, like your environment, your age, your sex. All of those things affect health. Like when we're talking about somebody that is 90 years old versus somebody that's 15 years old, and we talk about their kidney, there's a huge difference. A 90-year-old may be healthy for his age, but his kidney function has dropped down to like 80% or lower. But when you're talking about a 15-year-old, they should have maximal, roughly 100% kidney function. So both of them are healthy, but there's a big difference in their kidney performance. That's one factor of health. Cultural can be another one, or ethnic changes. If you go to a third world country and you look at somebody that's the same age as you, they may look really unhealthy, but in reality, for who they are in their environment, they're ideal health. They're perfectly healthy. So there's a big difference when you're talking about health. So when we talk about in this class health, we're going to stick with the World Health Organization term. And this thing's, what, 70 years old now? Roughly 70 years old. But it focuses on three things. It says health is a state of complete physical, mental, and social well-being. And those really have to be all in place for you to be healthy. It's not just the absence of a disease, so a physiological disease or anatomical disease. It's also mental factors, things that you could put somebody in an MRI and you can't see these factors in an MRI. Like schizophrenia. That person has a disease, but there's nothing in an MRI that's going to tell you, hey, they have schizophrenia or autism. So there's a mental aspect to it too, not just physical. Another key is social well-being. We're social creatures. We live with other people. In fact, one of the worst punishments we can give to anybody out there is to isolate them from society. So a criminal that's not only a criminal in society, but is a criminal in jail or prison, we put them in solitary confinement because they're so bad. It's our worst punishment. Think of just depression. Look at how depression can actually affect physical, mental, and social well-being. People that have depression, it could be a physical factor. It could be that they lack serotonin receptors or they lack serotonin the chemical. It could be mental. It could be some traumatic event that totally changed their way of thinking. They have the right receptors, they have the right serotonin, but their thought process has changed everything and caused depression. Or it can be social well-being. So somebody could be isolated. I was just in a school the other day and saw all of these bullying posters. Bullying posts, when kids are getting bullied, it causes social withdrawal, which causes depression and causes an illness. So just looking at depression, it can be all three of those things, or any one isolated, and it still means you're in absence of health. You have a disease. So now let's talk about the second hardest definition, which is disease. When we talk about disease, the disease is any deviation from normal structure or function of an organ, system, or body part. That's the general term for it. Disease is something you can actually measure. You can track it. You can see it. So when we talk about a disease, we're talking about the absence of this perfect homeostatic environment. Illness is when you show outward symptoms of it. So you can have a disease and no illness, or not show the illness. But when you have an illness, you have some kind of a disease. Magic Johnson is the guy in this picture here. He's a famous basketball player. I don't watch basketball, but I did back when he was playing a long time ago. And what's interesting is when you look at him, he's a happy guy, looks like a healthy guy, but in reality he has a disease. He has HIV. He has a disease in him. He can spread the disease. The disease is affecting the cells in his body. He's just not showing the illness. So there's an example of the difference. This last term, syndrome. Syndrome is when you take a group of signs or symptoms and you classify them together. We use the term syndrome more for when we don't understand the biochemical or biomedical background for a disease. Like, for instance, chronic fatigue syndrome. We still don't know all the biomedical explanations for it, so we call it a syndrome. It's a group of disorders that work together. Like, the patient has malaise, fatigue, they sometimes have bowel issues, but there's no biomedical explanation that's one great explanation, so we call it a syndrome. In the past, we've done this, and I know you're going to know this one, AIDS. Back in the early 1980s, we called it AIDS, the acquired immunodeficiency syndrome, because it represented a group of signs or symptoms. Weakened immune system, susceptible to other diseases. So we knew these syndromes. But when they actually found there was a biomedical explanation, the HIV virus, right? They didn't change the name from AIDS to AID, AIDD, acquired immunodeficiency disease. They left it as syndrome, which can leave it a little bit confusing, right? It's the same thing with like SARS, severe acute respiratory syndrome. We know the biomedical cause now, but when they first started identifying the problem, they just said it was a syndrome. There are a lot of them out there that are syndromes, like chronic fatigue syndrome. Fibromyalgia is actually a syndrome because we don't know the specific biomedical background. When we get to the brain and nervous system, we'll talk about some of the things that there are theories behind fibromyalgia, but it's still considered a syndrome. Irritable bowel syndrome, restless leg syndrome, those are all things that aren't really well explained by biomedical models right now. So there are three terms. The significance of those is when you see someone in a clinic, in the back of your mind, or any clinician, whether it's a doctor, a nurse, or anyone that's in the clinic, these are what we refer to the iceberg theory of diseases. For that one person that comes in, that you can diagnose and control their symptoms and signs, you have all of these things below that are floating out there. So this is the little bit that have been diagnosed properly, and you can control their symptoms or help cure their illness. Here, diagnosed and uncontrolled. So these are the people you can diagnose, but there's nothing you can really do about it. And then under the water, look at the bulk of the people out there. They are either undiagnosed, so they're walking around there with a disease, maybe even an illness. They're wrongly diagnosed, so they're sick, and there's nothing we know that we can do about it because we don't know what the disease is. And then there's another huge chunk of these people that are walking around with the risk factors for disease. And these risk factors are things that could cause the disease. So like smoking, like having exposure to certain chemicals, like having radon gas in your house. Those are all risk factors. And then there's this other group down here that are free of risk factors. So these are the diagnosed diseases up on the surface. These are the undiagnosed, wrongly diagnosed, or people that are potentially hanging out there with the ability to catch the disease. It's a huge group out there. And research basically is based on teaching you these different levels. Next thing you want to consider are adaptation. People adapt. And it's interesting because when you look at, and I learned this when I was learning about my dog actually, but babies and dogs, they compensate or they adapt for as long as they can, and then they crash. And if you've taken any clinical courses yet, you already know that. Whereas adults, our bodies adapt and we sustain this adaptation for a really long time. We slowly, progressively get worse. When you look at adaptation to the disease or the way we handle illness, it revolves around a couple factors like the timeline, the time of the change, how extensive the change is. And we're going to talk about how your cells adapt later and why you get symptoms for each of these diseases or signs for each of these diseases. So keep this in your mind. If you have a disease, you have like a bleed, we'll say that you have hemophilia and you have a break in a blood vessel. Losing a liter of blood might be something you could live through if you're an adult. But think about it as an infant. How easily are they going to live through that bleed? Or it could be two adults. Okay, one adult that's losing about a tablespoon a day. Let's say that they broke some blood vessels in their GI tract and they're losing about a tablespoon a day. A tablespoon a day is enough to cause anemia, but probably isn't going to kill you right away. It's going to make you feel terrible as it's chronic. Versus an acute bleed, losing all of that blood at one time on the inside. There's a huge difference in how your body adapts to those things. And when we talk about the diseases, I'll talk a little bit more about the adaptation for each of the diseases that is significant for them. Next thing we want to look at is the terminology between anatomy, physiology, pathology, and pathophysiology. The anatomy is the structure, and you learned this back when you took anatomy. It's how things are made. So what parts are where, what they're made out of, etc. Physiology is how they work. So how these things work together, how the systems depend on each other. Pathology versus pathophysiology is exactly the same. Pathology, we're talking about the structural changes. We're talking about the anatomical changes or the anatomy changes. So you can take a piece of tissue out of a person, a biopsy, you can slice it apart, put it on a slide. It's dead tissue now. It's not going to come back. That's pathology. Pathophysiology, the person's alive. They're sitting in front of you. You hook up machines to them to monitor the changes in their body, the function of the body. It can be as simple as just listening through a stethoscope to listening to function. So just as an example, if this is a nice healthy lung here, you can see all the alveolar walls. Here's somebody with emphysema. You can see the breakages. So you have this large alveoli. Right? This is an anatomical change. This is the pathology behind it. The pathophysiology is knowing what's going on. It's knowing that by having a larger surface area, a smaller surface area, larger alveoli, you're going to have slower rates of diffusion. Slower rates of diffusion is going to explain why they have a buildup of what gas in their blood versus not being able to get enough of another gas into their blood. So when you think about it, just knowing that little piece of physiology, you know that with somebody experiencing emphysema, they have these large alveoli with a small surface area. It's going to slow the rate of exchange of CO2 and oxygen. They accumulate more CO2 in their blood, and they can't get enough oxygen in their blood. So we'll talk about that as we come to it. But you want to know the difference between the two terms. The reason you want to know pathophysiology is because it makes it a lot of fun to learn, and I talked about this before. With pathophysiology, as soon as you understand it, when I give you a handful of symptoms or you're in a clinical situation and they give you the symptoms, right away your mind's going to start narrowing down the options to one disease. And you'll be able to predict the disease. By knowing the disease, you can reverse that. You can predict the symptoms that are going to come just by knowing that disease. And it's because you understand pathophysiology. You understand the processes. You can predict if somebody has kidney failure, what's going to come next. Well, you can think, the kidneys are important for making that chemical erythropoietin. If they don't make erythropoietin, what are they not going to be able to make? Red blood cells. Erythropoietin, remember, goes to the bone marrow, stimulates red blood cell production. So what symptom can you predict on somebody that's going through kidney failure or chronic kidney failure? Anemia. So you can predict the symptoms because you know the disease. All right. The next group is the terminology of etiology versus pathogenesis. The easiest way to remember this is etiology is what causes it. Pathogenesis is how it changes. So technically the etiology is, was it a chemical they were exposed to? Was it a virus, a bacteria they were exposed to? And a lot of times we can describe the etiology as being idiopathic, which means, I love this word by the way, idio meaning you don't understand. Pathic means the disease. So in other words, you're an idiot because you don't understand the disease. Idiopathic. Iatrogenic means the doctor did it. It doesn't mean you can have a lawsuit on the doctor for this. It just means that the doctor probably did it to save your life. A really good example of iatrogenic, like what causes hypothyroidism, might be iatrogenic treatment or iatrogenic because of the treatment for hyperthyroidism. In other words, you could went into the doctor with hyperthyroidism because you had a tumor growing in your thyroid. They removed it. They removed excess material to make sure it didn't turn cancerous. And now, since you don't have a full thyroid, you can't make enough thyroid hormone, so now you have hypothyroid. That's iatrogenic. Doctor did it, but they did it for a good reason. And the third one, there's nosocomial, which I'm sure you all understand, is that nosocomial is when you get it from the hospital environment. So MRSA is a big one that everybody's constantly talking about being nosocomial. And we'll talk about that when we get into the infection disorders. And then the pathogenesis is how it changes or evolves. So in other words, the pathogenesis tells you the progression. What's interesting is if you know somebody has a disease, you pretty much know the progression because of what we call the natural history. We know how diseases progress without treating them, so we can predict the outcomes. Right? So what's the actual ultimate expression of the disease? So two more terms. Let's talk about etiology just a little bit more. So etiology has three major categories. I know you can label it as iatrogenic, nosocomial, but there are three major ways you get a disease. So is it genetic, is it congenital, or is it acquired? So genetic means you got it from your parents. So I always joke and I say that genetic diseases are sexually transmitted diseases because your parents had sex and that's how you got it. But seriously, genetics means that the genes you got from your parents are what caused the malfunction. So it's passed down from generation to the next. Congenital means something that happened in utero. So something in that environment, you were given good genes, in other words. Your parents gave you good, healthy genes, but something happened while you were in utero. Maybe it was exposure to alcohol. Maybe it was exposure to chemicals. Back in the 50s, there was this chemical called thalidomide that was given to mothers so that they wouldn't get morning sickness. But unfortunately, thalidomide caused anomalies or malformations in the babies, which brings me to this. Anomalies are congenital changes that are just weird is the best way to think about it. It's something that's abnormal, that doesn't look right, like a third nipple or polydactyly. So one of the anomalies this thalidomide chemical would cause was flipper limbs, is what they referred to it as. These children were born without hands or without feet. They were missing pieces of limbs. They could live a normal, healthy life without those hands, feet. It was just a different thing from normal, and that's an anomaly. So polydactyly, having too many fingers, is an anomaly. It doesn't shorten your lifespan. Having a third nipple, anomaly, doesn't change your lifespan. But a malformation does. A congenital malformation is what we really call a birth defect, and a birth defect changes the potential lifespan. Like a malformation of a heart valve could be an example. Malformation of let's say, a vertebra that causes changes in the signals that come out of your brain and spinal cord, so you can't affect the sympathetic nervous system, and that would cause potential life-threatening illnesses. So those are congenital. An acquired disease is pretty much anything else, something you catch, so something you got from somewhere. Acquired disease can be a virus, can be because of bacteria, it can be anything, basically, because of a chemical in the environment, because I can't even think of any good, interesting examples. Those are all just examples of etiology. So the next thing is the pathogenesis. And when we talk about pathogenesis, we're talking about the progression of the disease, the evolution of the disease. And just to keep it all on track, I'm going to go right back to the World Health Organization definitions of pathogenesis and the progression of pathogenesis. They labeled this back in 1980 and said, here are the 4 major steps. So the first thing is exposure to whatever the pathogen is. And I'm saying pathogens as if it's an infectious agent, but in reality, genetics too. So as soon as you get the bad genes, right? Next is the preclinical phase, which means before this disorder takes you to the clinical because you have signs and symptoms that need attention. This is called preclinical. And then clinical phase is once you get there, it's the diagnosis and the treatment. And then the 4th step is the outcome. So what's going to happen to you either with natural progression of the disease or with the treatment. And I put the blood vessel example up here because here's a normal blood vessel. And then you start getting accumulation of fatty deposits. We're going to call this preclinical because these fatty deposits, even if you feel healthy, you probably have fatty deposits in your coronary arteries right now. As it progresses, it's going to make you have signs and symptoms like weakness walking upstairs. You're not going to be able to tolerate exercise the same. So, man, thinking about these, I think, geez, I better get checked out because I can barely handle the 5 steps to get into my front door anymore without breathing heavy. But these are the clinical signs and symptoms. And then the possible outcomes could be things like throwing a clot, blocking up blood vessels, causing necrosis of the tissue, causing the pain, causing angina, heart attack, myocardial infarction. All of those things are the possible outcomes. And we'll talk about these a little bit more as I walk through them. So let's start off with what constitutes preclinical. So you've got this disorder, this disease. Preclinical stages are when you have it in you, but you can't actually, well, you can see it. You aren't at a stage where you have to go to the clinic to get it checked out. So it's in there. It causes changes, but you may not be able to physically see it without special tools, like morphologic changes. Even when you look at things like, fatty deposits, you can't see that, but that's a morphological change. It's shrinking the diameter of the blood vessel and making changes in your life. Until this gets so extreme that you're not getting adequate blood flow to the heart, you're not going to know it's there. You have no idea. So we have this time called the latent period when you have the disease but there are no physical symptoms. If you're talking about an infectious agent, we could talk about something like TB. TB gets into your body. One little tiny bacteria isn't going to cause a huge difference until it has a chance to replicate and multiply. So we call that an incubation stage. But it's while it's in your body, you have no clue. You could be spreading this, by the way. You could be coughing on people and spreading your TB onto them. You could get an STD and be transmitting this STD before you even have signs and symptoms that bring you clinical. This is preclinical. Next are what we call prodromal period. And this is when the signs and symptoms start first appearing. So a lot of times these things come on insidious. And I love this word because it just means it creeps up on you in a scary way. It's the way I think of it. So insidious means that these signs and symptoms like headache, fatigue, a cough, these things are just mild signs, and you think, well, geez, it's been a bad week, it's been a rough week, and you really just disregard it, and you say, I'll get a little more sleep tonight. So you sleep a little bit later, you say, it's my boss has been pushing me. So, you just try and relax a little bit more, but the signs and symptoms don't go away. They're there. They're coming out, but they just they're not so extreme that they have driven you to going to the clinic yet. Right? So we also call this subclinical, not clinically evident. There's actually subclinical is used in another way. Like, for instance, some viruses. You can get the virus, you have it in your body, but when you take a test for that virus, it doesn't show up. So, for instance, HIV. If you contract HIV from sexually transmitted sexual transmission versus blood transfusion, it takes longer for HIV to become evident in your blood tests if you get it sexually transmitted. So, and I'm kind of hinting at one of the questions that's going to pop up pretty soon. I'm going to have you look that up. During that time, though, you're still a carrier. Just because it didn't show up on a test doesn't mean you can't spread it. So this is referred to as being subclinical. Which brings me to the next question. So this is homework question number 2. You know that because there's a little 2 up here in the corner. You want to write it down because the little guy's writing it down. And you also see the web link, which means I want you to go on the internet and find this. And again, remember the rules. Go to .govs, .edus, .mil, .org, but be careful of tons of ads and personal opinions. I want facts. So go to a site that you can trust to be full of facts. If you wonder if it has facts, look at the bottom. Do they have references? Go to the references. If the reference is from a reputable journal or it's from one of these other sites like a .gov site, then go to that site and use that instead. So a lot of people put their personal opinions out there, but go seeking the truth. Don't just assume it's the truth. All right, so homework question number 2. And I'm going to point this out right now. When you're going through this, it may look like a lot. I don't want you to write me a book. I don't want you to write me several paragraphs. I don't want you to go super in depth. I want you to treat me like I'm a layperson when you explain it. What I want you to get out of this class isn't to be able to speak so perfect technical that if you ever deal with a patient that they don't understand what the heck you're talking about. I understand the biochemical background. I understand all the physiology that's going on behind, or I like to think most of the physiology that's going on. I want you to explain this to me as if I'm a layperson, because when you get out into the clinical environment, that's what the people are. They're not going to come in with these super medical questions. You are going to understand through the process of this class understanding medicine, but I want you to be able to explain it in layperson terms. So I'm going to have you, for most of these homework questions in this section set, looking up HIV. So you're going to describe the preclinical phase of HIV. What's going on in them before they're actually in the clinic? What caused the HIV? So what are the causes that they could have gotten it from? What happens to their cells? So what's the cell morphology or change? Morphology is referring to the physical changes of cells. So what cell does it attack and what does it change? And then, are they contagious during the preclinical phase? So can they spread it? How long are they in the preclinical phase if they get it from sexual transmission? Not blood transfusion. There's a difference. So how long are they actually in the average person in the preclinical phase if it's sexually infected? So how long before it even shows up in their blood tests is what I'm looking for. And how do we diagnose them during the prodromal phase? So when they're first getting those signs and symptoms, what are some of those signs and symptoms that start setting in before they come to the clinic? So again, it seems like a lot, but you can answer this in probably less than 3 sentences. So I just want you to run through and explain this. So how do they get it? What cells does it affect, and how do the cells change? Are they contagious? How long have they had it before we can actually identify it? And then what are the first signs and symptoms that start setting in insidiously? Pretty easy explanation. So here's where you want to pause and write this question down and find the answers. Okay, next. Clinical manifestations, so step 3 of the pathogenesis. So the clinical manifestations are what brought them in. Again, this is a terminology issue. Signs versus symptoms and subjective versus objective. I make this pretty general. So subjective means that you can lie about it. If a person comes in and it's something that they tell you that you can't actually measure it yourself by sticking some kind of a monitor on or in them, then it's subjective. Pain. We don't know. Pain is so subjective. If I prick you in the finger with a needle and prick the person sitting next to you in the finger with a needle, you both can rate this differently on a pain scale. It's subjective. It's something you can exaggerate. You can come in saying, "Oh my God, I'm in so much pain," but in reality, you have a paper cut. Dizziness, there's no way to measure that. I mean, whoa, I'm tilting and I'm about to fall over. You can fake that. Difficulty breathing, anybody can use their accessory breathing muscles. These symptoms are subjective. They're things that could potentially be faked. Don't assume the person's faking it, but they're things that could be faked. So symptoms, you usually want to rely on the signs, and the symptoms are just kind of like extra information to help lead you towards a conclusion. So the signs are things you can measure. Temperature. Stick a thermometer in their butt. Ta-da! Temperature's taken. Swelling. So if you look at the right hand versus the left hand, you can definitely see if they're swelling, right? If you look at their pupil changes, shine a light in their eye, you can see the change in the pupils. These are things that you can directly measure if you wanted to. So signs are things that are objective. They're things you can measure. Signs are signs that the body is compensating for something. There's something broken in the body, and the body's trying to change to it. Right? And we'll talk about adaptations in the body that you're trying to compensate for later. Complications and sequelae. So complications are things that happen kind of as a side effect. So you can think of complications as being something that happens in addition to what you would expect to happen. So a complication of kidney failure, I think I kind of talked about this a little bit already, but if somebody's kidney's failing, there's a hormone they can't release that affects their bone marrow. Do you remember what that hormone is? Starts with an E, starts with an erythro, and it ends with a poietin. So it's erythropoietin. If you remember, the kidney monitors your blood, your oxygen count in your blood. It releases erythropoietin, goes to the bone marrow, and makes brand new red blood cells. If you don't have functioning kidneys, you don't release erythropoietin. So what would be a complication of kidney failure? What disorder is actually a sign or symptom? Anemia. So a complication that could be a result of kidney failure would be anemia. And a lot of people wouldn't know that, but because you know your physiology, you know. Erythropoietin goes to the bone marrow. You can't make erythropoietin, bone marrow doesn't know how to make red blood cells. Right? So signs and symptoms of a heart attack would be something like this. So we already talked about the preclinical phases when your blood vessels are narrowing because you have all these fatty plaques. And then eventually when you're not getting good oxygen to your heart, an issue here is that people start having symptoms of pain radiating down their arm, going across their back, shooting up on their jaw or the side of their face. Right? The signs, the objective things, are when you take a blood sample when they come in and they have changes in creatine phosphate levels or creatine phosphokinase levels, changes in their I'm goofing up, ECG. So many abbreviations in my head. So those are things you can actually measure. Blood levels of certain chemicals, changes, electrophysiological changes. Symptoms would be an example of pain shooting down their arm. Right? Or sequelae are just the order of things that appear. So we'll talk about this. And when you see lesions, lesions don't mean a physical structure you can see. Lesions can be a biochemical change, like mitochondria. When somebody's having a heart attack, the mitochondria don't work properly and they start producing reactive oxygen species. You can't see that. It's just a sequelae. We know if the heart's not getting oxygen, and we'll talk about this in a little bit, the mitochondria can't work. You know this. Mitochondria normally make ATP. They don't make ATP, and instead they make free radicals that destroy the tissue. Those are sequelae. It's a progression. We know that if this isn't fixed, then they get necrotic tissue, so the heart starts dying. So here's actually an example. You can see there's blocked blood flow. This tissue starts dying. Here you have the mitochondria that are exploding and killing the tissue. And then what happens is all of the blood downstream becomes necrotic. When we describe how this is changing, we refer to it as systemic and local. So systemic means it's affecting the whole body. Local means it's specifically in one area. So like necrosis or gangrene is a good example. Gangrene of the foot is local. Edema can be both systemic and local. So if edema is local to the foot, maybe the person's working on their feet all day. When it's systemic, it's their whole body. You see swelling in the hands and the arms, the legs, the feet, everywhere. When we talk about one specific organ, we talk about it as focal or diffuse. We're going to hear this in the brain a little bit more. Focal means it's one location. Diffuse means it's all over. So a focal lesion in the brain means one spot in the brain. You can have seizures or abnormal electrical activity that's focal in the brain and just affects one thing. Usually when you hear about epilepsy, it's diffuse. It causes this one area to go all the way across the brain and affect the entire brain. That's referred to as diffuse. When we talk about evolution of a disease, we can refer to it as acute, chronic, or in between, which is subacute. Acute means it sets on quick, the symptoms come on really quick, the signs come on really quick, and a lot of times it's fatal really quick. Chronic means that it's usually the same signs and symptoms, but they come on slower. They creep on. They're usually not as fatal. Okay? So chronic, and we'll talk about this with leukemia a lot, if you have acute leukemia, it's usually fatal in a short amount of time if it's not corrected. Or some people can have chronic leukemia that slowly gets worse over years and years and years. And a lot of times those symptoms are insidious. They're the same symptoms as acute, but they're so spread out that people don't really recognize them. They're kind of hidden a little bit. When we talk about multiple sclerosis, we'll talk about it's a chronic condition. It's a degenerative disorder that keeps getting worse with time. We'll talk about its exacerbations, when the symptoms get really bad and then they'll go into remission where it feels like the symptoms went away, but in reality they're not back to as well as they used to be. Chronic conditions are usually progressive. They constantly get a little bit worse over time. And of course complications we already talked about. So the next question you're going to want to write down, question number 3, is describe the clinical phase of HIV. So I want to know the signs and symptoms, the distribution of HIV, and the complications that come along with HIV. So again, layperson's terms. Don't give me a super technical. When I'm asked for signs and symptoms, what are the signs and symptoms that usually bring them to the clinic? What's the distribution? So what parts of the body does it affect? And then the complications, what usually is an outcome. So what happens because they have this disease? And as you're looking through HIV, you'll realize that HIV actually doesn't kill anybody. HIV leaves the door open for, well, you figured that out. So pause, write down, and then come back. All right, so differential diagnosis. Differential diagnosis is finding the actual origin of the disorder. People come in with a ton of signs and symptoms. And remember that word syndrome just means a compilation of all of these different signs and symptoms. Syndromes are usually very vague. They can be lots of different things. And I'm using this as an example because since you're in a medical class, what's the first thing you worry about with this guy grasping his chest like this? Right? You think a heart attack. But when you ask him to describe things, he has pressure in the center of his chest. It hurts, kind of burns, it feels very painful. His chest discomfort, has nausea, sweating, okay? Feels like he's lightheaded and could possibly faint. Does that mean he's having a heart attack? It could mean he has indigestion. He just ate some spicy meatballs and now he's burning up inside. Maybe he ate a ghost pepper. You never know. So those are very vague. But when he says that the pain's radiating down his arm, goes across his shoulder, neck, back, on the side of his face, then you start worrying because that allows you to give a differential diagnosis. So far, what are these? Are these objective or subjective symptoms? All three of those are subjective, right? You can fake pain or pressure in the center of your chest. You can say that. You can say, oh my gosh, I feel nauseous. You don't have to vomit, right? You feel nauseous. You can say pain shooting down your arm and neck. So when you look for objective signs, once they get in, they'll take blood samples and then they'll help diagnose. They'll hook this person up to an ECG, help diagnose. Right? All those pieces of information together are the differential diagnosis. Our goal through the semester is to give you enough signs and symptoms that you can narrow it down, and I'll help point them out. But usually there's one or two certain signs that are giveaways for diseases, and we'll talk about those, or I'll try to point them out as often as possible. Right? And then prognosis is predicting the outcome. So once we know what's wrong with this person, we know that if we don't treat them right away, what's going to happen. So if we don't give them an anticoagulant, this person with a heart attack, there's a risk that they could have a stroke. You know, they could throw a blood clot, have a pulmonary embolism, any of those things. We know the treatments, so which I actually just kind of said. So we can treat them with anticoagulants like aspirin to help prevent those damages. They can put in stents and whatnot. So those are just some examples. All right. So then the outcomes. So outcomes of disease, mortality, morbidity, or no outcome at all. You know, like perfect health regain are basically the three main areas. But when somebody has a disease, you don't really usually see a 100% cure. Usually you see mortality or morbidity. So to make life simple, mortality means death. All right. So of what percent of these people will have mortality, we refer to that as mortality ratings. In this situation over here, diabetes complications, about 7% of people with diabetes are going to die because of diabetes. But the bulk, about 93%, are actually going to have morbidity. So they're going to live through it, but they'll probably have other complications. So the morbidity are things that happen that change the person's way of life, the way they live. Right? So poor quality of life, they're not as productive as they used to be. A good example of diseases would be arthritis. Arthritis has an extremely high morbidity rate, but it has a very low mortality rate. In fact, I've never heard of somebody dying of arthritis. Doesn't mean it couldn't happen, but I've just never heard of it. So high morbidity, but low mortality. When you look at diabetes, diabetes can actually affect both, and you see that in the pie chart up above. So diabetes can affect things like pain sensations, which prevents them from living a normal life. That's morbidity. Diabetes can cause them to lose a toe, which keeps them from working appropriately. That's morbidity. Diabetes can cause heart disease, which kills them. That's mortality. Right? When we look at morbidity, we want to think these terms: impairment, disability, and handicap. So examples of morbidity would be impairment. Impairment would be, I'm thinking of a really good example. Impairment actually doesn't always have to be something that you can physically see. An impairment could be something like when we talked about the blood vessels before. Atherosclerosis, that's plaques inside the arteries, are accumulating. It could cause an impairment. They can't exercise as well as they can, which means it may change the way they do their job. You know, if they're working on their feet all day or they're a gardener or something like that, it's going to change the way they perform. If they're lifting heavy things, it's an impairment, right? So these impairments can lead to more signs and symptoms. So lightheadedness, pain in the chest, all of those things that we talked about. Disability can mean a consequence of impairment. Disability means that it changes them from being an average person doing average things to losing the ability to do some of those activities. So this revolves around their normal performance as a human being. Right? So if chest pain is causing them from being able to walk, that's a disability. If pain radiating down their leg is keeping them from walking and doing their job, it's technically a disability. It's an impairment, but it's also a disability. If it's preventing them from doing their job or their role, you know, their normal roles as an individual, we call it a handicap. So a handicap is basically anything that prevents them from fulfilling their social roles. Migraines can actually cause a handicap. You know? Pain can cause handicap. Anything that causes economic hardship, loss of income, social position, those are all considered handicaps. So if we look at a chart like this, leading causes of death in the United States would be an obvious example of what? Morbidity or mortality? Mortality. And you see the number one cause of death in the United States is heart disease. Number 2 is cancer. Number 3, strokes. So here are our main causes of death. Can any of these cause morbidity? Sure they can. Yeah, you can have a stroke that causes morbidity or disability or even a handicap. You can have heart disease that causes handicaps. Right? You have a cancer that does the same thing. So if we look at another chart here, it says leading causes of disability. And disability, of course, is a type of impairment, which is a type of mortality or morbidity? Morbidity. And like the example I gave before, arthritis. Arthritis is the number one cause of disability in the United States. Okay. Number 2, spine and back problems. So things that won't necessarily cause mortality, but things that could definitely make your life or your functioning life completely different. I think this is a really neat chart. There's actually another term called disability adjusted life year, and what they do is they take into consideration that if the person doesn't die what kind of effect does this morbidity have on their productivity in life? And you can see two of the major factors that decrease productivity in a year for a person are cardiovascular disease and cancers. You can see things like respiratory diseases, emphysema, asthma. Those are also. So the way I simplify this in my head is that if it takes you a year to do a certain job, this person is going to take them extended way beyond a year, maybe take them a couple of years or more. But the major things that slow people's productivity are actually cardiovascular, cancers, and respiratory. Next question. So homework question number 4, write it down. What are the outcomes of HIV? So I want you to tell me in this outcomes of HIV, what are the examples of morbidity, okay, what disease does HIV become, and after how long, which I'm hoping you don't have to look that one up, but maybe how long? How long does it take to become that second disease? Right? And then what's the mortality rate of HIV last year? Don't forget to cite your source. Just put a copy and paste the link underneath your answer. I want to make sure that you're going to the right sources. So hit pause, write down the question, find the answers, and come back. Next is the natural history of disease. I talked about this a little bit earlier. Natural history of the disease means that what would happen if we didn't treat it? When HIV was first coming onto the scene, HIV's been around since we predicted it came around 1908. But the first recorded cases were way back in 1959 in Africa. The natural history of the disease, we watch how these people die without any medical intervention. That's the natural history. There's a benefit to knowing this information is that we know the natural progression of the disease. And the best thing about it is that when we treat someone, we can know, does the treatment work? So we can look at all these factors that can change somebody's lifestyle or cause death. We can change one of them with a treatment and then see what happens. So how long do they go through these different phases? So the biggest benefit to natural history is it lets us look at the outcome. And there's some diseases we can still track the natural history. Like hepatitis, we really don't have an effective cure for it. So some people, we just have to watch them go through the progression. And then we can record that progression and know if the next person that has the same disease, if we treat them, will make a difference. Next thing we know are the 3 levels of prevention. So there's primary, secondary, and tertiary. And the word prevention I put in big and bold here is because prevention means different things. We're not talking about preventing them necessarily from getting the disease, but once they have it, preventing them from moving or progressing to worse stages. So primary prevention is the actual prevention of the disease. When you get vaccinated, that's a primary prevention. It's trying to keep you from getting that disease, period. Wearing a condom prevents you from getting sexually transmitted diseases. That's primary prevention. Secondary prevention means that the disease is in your body. It's in there, and now we want to make sure it doesn't progress to something worse. A good example of this is when people get a pap smear. If they have HPV, we know they have something that could cause cancer. It's in their body. Now what we're doing is we're trying to early detect it. So if we take a pap smear and those cells are abnormal, then they'll go and do a biopsy, and then they could potentially pull out the cancerous cells. Right? Tertiary prevention would actually be the removal of the cancer. So we know that it's developed into a cancer. We can give them chemotherapy. We can remove the cancers. Those are examples of tertiary. So those are all 3 levels of prevention. It's just when are they going to happen? It's different. Right? And then I also had an example down here, beta-adrenergics reduce the risk of death following heart attacks. We know that when people have a heart attack, it changes the way that their heart performs, so we can give them medications that prevents them from experiencing death. And then the 5th question, and I think this is the final question for this set of information, but we learned about the natural history of AIDS when it was what called? We learned about the natural history of AIDS. We're actually going to talk about this in a lecture when we meet for the first lecture day. We're going to do a little extra credited assignment that follows it, but I want you to look up what was it originally called. And it was actually called or named after the community of people that were showing signs and symptoms of it at first. So back in 1981 in Los Angeles, there were 5 people that were showing abnormal situations, and they found that they were all part of the same community, so they gave it a temporary name. And I want to know what that name is. And then in 1982, they actually changed the name to AIDS. So what was the original name? And then what are the 3 levels of prevention in HIV or AIDS? So go back and what's the primary prevention for HIV? What's the secondary prevention? And what's the tertiary prevention? Pause now, write it down, and come back when you're ready. Right, and then epidemiology. So epidemiology is the study of disease and populations and how it moves across the population. And when you're looking at this, there are a couple of factors they look at. One's called precipitating factor and risk factors. So we don't just study who has a disease, where it went all the time. We also look at who has the ability to have the disease and carry the disease. So precipitating factor is something that causes the disease or the pathology. So we also call it the provoking factor. Where risk factors are things that are contributing to the disease. For instance, breast cancer. Breast cancer, we know, has links to a gene called the BRCA, BRCA gene, BRCA. That's a genetic thing. You get that gene, and that's a risk factor. It contributes to it. But just because you have that gene doesn't mean you're going to get the cancer. There are a lot of other things in the environment that will actually trigger that cancer, like smoking, like exposure to certain chemicals, like exposure to x-rays. All these things can actually cause the cancer. It's just the risk factors contribute to it, contribute to its development. So here's a little exercise, homework number 6. Look up a couple risk factors. So precipitating factors, they can cause heart disease, adrenal adenomas, which means a tumor on the adrenal gland, polycythemia, which means too many red blood cells or thick blood. These are all things that are precipitating factors. But what are the most common risk factors for heart disease? That's all you have to do. And I think by now you figured out, look for sites that are .gov, .org, but not personal opinions, and .edus. Same thing, not personal opinions. Pause the tape, write those down. All right, and then the last couple slides. So when we describe terms of frequency of disease in epidemiology, we refer to incidence and prevalence. Incidence is the number of new cases. So how many times per year does a new case pop up? Prevalence is how many people overall are walking around with this disease. And there's a big difference, and the terms are kind of important. So if you look at a chart like this, and this is a chart measuring HIV. So this graph says the incidence of HIV actually dropped going along this chart. When you look at this, the prevalence actually rose as you go along. So when you look at a chart like this, you want to ask yourself, what does this mean? When you look at this, let's say that right here in 1995, we started introducing new treatments or new education. We'll say new education. We started informing the public about HIV, how you get it, how to be cautious of it, how to prevent it, all of these things. In 1995, did it work? So if we look, the incidence, the number of new cases after 1995 started dropping. So yeah, it had some success. It had some kind of success. Right? That same year, in 1995, we introduced new treatments. Did they work? Okay. New treatments are talking about keeping people alive, keeping people as healthy as we can for a long time. And you see from 1995, the number of people staying alive actually increased. So this chart tells you a lot of things, depending on what you're asking, I guess. So looking at prevalence and incidence, there's a difference. We can compare different charts. So we can compare how successful were our interventions. So were we able to prevent people from getting HIV? So if we predicted and then we introduced a change to see how much things were averted or if they were avoided. And if I remember right, this is an actual chart from some research that was for HIV education, and they found there was a 25% decline in HIV by 2010 because of the research that they were conducting and the information they were providing. Here's another way you might see these on a chart. So prevalence and incidence of obesity and diabetes. And these are two prevalence charts. If you look, you could actually compare. You can see that prevalence of obesity, there are people, maybe it's saying that they're living longer. Okay? It might also be indicating that there are lots of new cases, but those people are staying alive. And the same thing with diabetes. You could actually look at these charts, and if you compare them, whoa, there's a correlation going on. So it looks like the rates of people living with obesity is increasing at about the same rate of people living with diabetes. So you could say there's a correlation there, not cause. And then this is the last slide. And when we meet in class this week, we're actually going to do a little study of epidemiology. And this is one of the original epidemiology cases. In 1854, John Snow was actually tracking cholera. And he was looking at cholera in London and said, it seems like most of the people in London that have cholera are in this little circle of area. And he found that all those people, or most of those people in that circle, were getting their water from the same well. Originally, they thought it was miasma, which, if you remember from the first video that you watched, miasma was gases or vapors that were causing disease. And he said, no, this isn't realistic, because gas and vapors can go even further. And so he decided it was probably because of water contamination. The only thing these people had in common was water. So they took the pump in the middle of the town, and he got the policeman to come along and take the handle off the pump so nobody could get any water out. So then they had to start getting water from other areas. And he found that when they took the handle away, people were getting better. I mean, the number one most effective treatment for cholera is clean water. Right? Cholera causes diarrhea, dehydration, and then death. People start drinking clean water, they quit introducing cholera to their GI tract, and then they start getting better. So when we meet for class, we'll do an epidemiology study on HIV, and don't forget to watch the next videos. Talk to you then.